So welcome to Maz, and thank you for agreeing to talk to us about what makes a high-quality upper GI endoscopy report.
Thank you. The pleasure is mine. Some days ago or weeks ago, I got the task for preparing this talk, and this is a topic that I have never talked about, so that was really new to me, and it was an interesting journey that I took during these preparations. As always, just as a general remark, I think I have learned the most of this presentation, and I hope that I can give something back to you. So reporting is giving information about the procedure, giving information about what has happened and what our interpretation is of what has happened. And if we consider the target population who is going to read our report, it might be the general practitioner, the hospital staff, or the future ourselves, or another endoscopist. And all these people might be interested in a different aspect of what has happened and what our interpretation is. The patient is, of course, interested in understanding his pathology or the reassurance what pathology, benign or malignant, he has. And a health insurance company or the payer body is interested probably in a totally different aspect of the procedure. Different societies from Europe and from America has set up a minimum standard data element list that a procedure report should contain. And there are, yes, obvious parts of that. So when was the procedure? In whom was that procedure done? Who did the procedure? With the help of who? So endoscopist trainee, what is the patient history? What is the medications? And yeah, it's a comprehensive list or a minimum list, but I will not go through every element of that. Basically, they can tell us how much percentage of the mucosa was visualized, and AI can be of a help. This is published 4 years ago in GUT, where doctors from the Far East came up with a real-time AI algorithm that assessed the blind spot miss rate. So it categorized the real-time image flow into the different parts of this 22 blind spot or cardinal landmarks of the stomach, and prompted in half of the procedures the endoscopist that, look, there is a blind spot which was not imaged yet. Common criticism of these is that, has ever a study shown increased neoplasia detection rate? And the answer is, it is very difficult to show increased neoplasia detection rate. Why? Because it is a rare event. And if you consider an RCT and a sample size calculation where you want to increase the detection rate by just 0.1%, so from 0.2 to 0.3, that study needs 80,000 participants to show significance. And probably this is the rate where early gastric cancer occurs. However, if we look at a very enriched population, so like 0.5 to 1%, that study, which is, I think, still an enriched population, so not very easy to gather these patients, still this study needs 10,000 patients to
show a difference.
We are supported with the standardized terminology. Prague classification was talked about and introduced. Just make sure that the circumferential is not high, is not a bigger number than the maximal extent. And yeah, there is data also that if you comply with these guidelines, that so you take your photo documentation and you use adequate terminology, that is associated with a higher dysplasia detection rate. Of course, this is biased with the normal bias pattern of retrospective trials, which is like, yeah, you cannot know whether the terminology used was because of the dysplasia was detected and therefore better descripted, or the other way around. But anyway, the association is not the opposite. So if you use them, you probably have a mindset that is prepared for finding dysplasia. Los Angeles was mentioned. In the esophagus, where you see something darker, you just can refer to the IPCL patterns. That is either regular, regularly irregular, or irregularly irregular, and it has, of course, these other names like A, B1, B2, but it comes down to the regular and irregular patterns as well.